Bienvenidos a todos. Esto es una nueva jornada de actualización de Fundación Zambrano. Acá justamente vamos a presentar a la doctora Grazia Pertile, que ella es jefa del Ospedale Sacro Cuore Calabria en Negrar, Verona, en Italia. Ella se formó en la Universidad de Maastricht, en Holanda, y luego trabajó muchísimo tiempo bajo la dirección del doctor Karl Claes en el hospital de Middelheim en Amberes, y bueno, tiene muchísima experiencia en trauma y en patología ocular compleja, quirúrgica. Bueno, vamos a mencionar también que este seminario lo vamos a estar transmitiendo ahora por Faco Extrema también, como una ocasión especial. Así que también tenemos de panelistas al doctor Alberto Zambrano, al doctor Tomás Castro Feijó, al doctor Gastón Gómez Caride, y bueno, quizás se conecten algunos más tarde para hacer después al final las preguntas. Así que ustedes pueden mandar las preguntas en todos los canales, en Facebook, en Zoom, los que estén conectados, y también a través de Faco Extrema, que vamos a estar después pasándole las preguntas al final a la doctora. Doctoressa, è tutto suo.
Grazie. Now, Julio, thank you very much for your kind presentation. And it's a pleasure to share with you some experience in treating trauma cases. And I think we can start with a presentation, and then we will stop from time to time, and we can discuss some points if you agree. So we can have some discussion through the presentation instead of doing the whole presentation and stop at the end.
Okay, there's no problem. And then as well in the end we can ask questions, right?
Yeah, of course we will have time at the end, but if you have any question in the meantime and you like to stop me, feel free to stop me at any time.
No problem.
So we all know that trauma cases are quite tricky often. They are not easy cases. There are a lot of challenges in treating trauma cases. So I like to share with you some difficulties and some tips and tricks, so to speak. So I titled my presentation, What is different in trauma cases compared, for example, with traditional retinal detachment. We all know the definition of trauma damage due to injury, and we have the closed globe trauma and open globe trauma. And a closed globe trauma can end up in a contusion, often in a lamellar laceration, and then we have open globe trauma with rupture from one side and a laceration due to a penetrating foreign body, so a foreign body that causes the trauma, but then it is removed. We can end up with an intraocular foreign body, a foreign body that remains inside the eye, and a perforating trauma when the foreign body goes in and out the eye, leaving the damage. You'd say now closed globe trauma has nothing to do with vitreoretinal surgery from some sides, but from time to time you end up with this large retinal laceration due to the rapid deformation of the globe. So after even a closed globe trauma, we should check the retina, the peripheral retina, because it is not unusual to find retinal laceration like this one. This is a small one. You can treat this with a laser probably, but you can have also larger peripheral laceration like a retinal dialysis. And you probably know that retinal dialysis, a traumatic retinal dialysis, is typical in the suprarenasal quadrant, while the spontaneous idiopathic retinal dialysis is more frequent in the infratemporal quadrant. So after a trauma, check the suprarenasal quadrant for retinal dialysis. We know that retinal dialysis is different compared with giant retinal tear. And the main difference is that one is a detachment at the ora serrata, while a giant retinal tear is a real laceration through the retina. So you always have an anterior retinal flap. Unfortunately, the pointer is not working at this time, but I'm sure you know what I'm speaking about. So if you want to distinguish retinal dialysis from giant tear, check the periphery, and if you find an anterior flap, this is a giant retinal tear. Why is it important to get the right diagnosis before the surgery? Because the approach is completely different. Retinal dialysis should be treated with an external approach with an encircling element, while almost always a giant retinal tear need a vitrectomy, the release of attraction. In addition, when you have a giant retinal tear in trauma cases, you should check the condition of the vitreous, because quite often you get a giant retinal tear with an attached vitreous. And nowadays, the easiest way to check the condition of a vitreous is to do an OCT if you don't have a vitreous hemorrhage, and you can easily check if a vitreous is attached or detached. This is important because you probably know how difficult it is to detach the vitreous in a detached retina. This is an example. This is in addition a high myopic eyes. I hope the quality of the picture you get is of enough quality to be able to see the details.
Yes, the video runs fine.
Yeah, it's fine. You can see the details. So in this case, it's easier to use. I use triamcinolone to detect the vitreous and to see if it is attached or not attached. And I like to use a bimanual technique with an independent chandelier light to be able to use a chisel. I like to use a vertical chisel. You can use it as a pick, but also as a chisel to cut it. And then you see, when you find the edge, you can progress in the delamination, because what you usually do is use the aspiration of the cutter, but in this case, when the retina is detached, we run the risk to get the retina inside the cutter and to cut the retina even in the posterior element. So be careful. Sometimes when you have an open globe injury, you have also a vitreous hemorrhage, so you have a more complicated condition. And then in these cases, it is important to proceed with the repair of the injury of the globe before you go on with the vitrectomy. In some cases, you get a globe laceration outside the cornea. And so when you watch at the eye is intact, you have no particular problem, and it looks fine, but how can you detect if there is a posterior laceration or not? few trips where you check the intraocular pressure when you have hypotony. This is suspected for posterior laceration. You do ultrasound, and if you find a position of vitreous incarceration, this can be a sign of a posterior laceration of the globe. And sometimes it's also used for CT scan, because when you see deformation of a globe, the volume is less than the other eye. This is suspected for a posterior laceration, and then you should go on and check the integrity of the globe, open the conjunctiva and check for the integrity of the globe. What is different in traumatic retinal detachment compared with normal detachment? We see here, for example, one typical trauma. In this case, there was incarceration of the iris in the suture, in the corneal suture. You see here the removal of the lens. And then finally, after the removal of the vitreous hemorrhage, you see the retina. You see this position, the incarceration, where you see this whitish condition. It is the site of incarceration of the retina. First thing in my experience is to remove the cortical vitreous, and then to go on after removal of the cortical vitreous. You see here all around this large clot that prevents the vision of the site of incarceration, and you really need to remove the retina in this side, and then you really have to cut out the retina all around the incision site. Do you have experience concerning the incarcerated retina, how to remove the retina? What is experience about this?
I think Tomás Castor-Feijó, he has more experience than me. He's the one who taught me retina. So maybe Tommy?
Do you agree that it is important to, for example, there are two opinions. What I usually do in conditions like this, what you see on screen with incarcerated retina, I first remove the cortical vitreous and the cortical vitreous, and really cut out the retina all around the incarceration site. And I used to do some coagulation all around the site of incarceration. Do you think, do you agree that it is important in preventing the retina from scarring into the laceration point? Do you usually do so? What do you think?
Tommy, Alberto?
May I?
Yes.
I
agree.
Sorry, go ahead, Tommy.
No, go you first, please.
No, I learned from Relya Sivoinovich that the best thing to do is to cut the retina, the incarcerated retina, let it free, and go on with the surgery. And usually we do that with a thorough coagulation of the retina before cutting it. And usually it works. And you also avoid the proliferation from outside the eye into the eye. It was described many, many years ago from Bob Mackhammer and this group. So, well, I'm talking about many years ago, the years I'm working in this matter.
Yeah, I think it is, it is important to remove the retina all around the incarceration side. And also I found useful the suggestion of doing some coagulation of the RPE and choroid all around. Because sometimes
chorioretinectomy.
Pardon?
The chorioretinectomy.
The chorioretinectomy, correct.
Okay.
The chorioretinectomy, because I think it is useful to prevent the scarring, because sometimes after a couple of weeks or months, you get the retina again inside the scar, the site of the perforation. While during the chorioretinectomy with coagulation, diathermy, it's in most of the cases it is able to prevent this new scarring. On the other side, you know, when if a damage, like in this case, is very close to the posterior paw, in these cases it's quite tricky to decide if you want if you have to go on with a chorioretinectomy close to the fovea or to leave it like it is. But maybe we have some example later on.
Okay.
Okay. Are there other questions on this topic or?
Tommy, Gastón, ¿alguna pregunta?
Oh no, everything is fine.
Maybe we can.
No, thanks. I agree with everything.
Okay, thank you. Now, another important topic when we speak about trauma, but also PVR, is retinectomy. We have already said that it is important to do a retinectomy close to the site of perforation, of scleral laceration, but quite often, except this site, you get some traction, anterior traction at the site of due to PVR. And in these cases, you have to decide if you want to do a retinectomy or not. So my rule is in general, so something different from the incarceration site, anteriorly, do a retinectomy as anterior as possible and as small as possible. And I'm going to explain what I mean. The idea is when you have these small atrophic holes of an oral dialysis, almost never you get a PVR, while in giant retinal tear, you often have PVR. In these traumatic cases, you quite often have an interruption of integrity of the retina, and this activates glial cell and promotes PVR. It is a well-known phenomenon that glial cells are an important source of cytokine and inflammatory factors, and this is a promoter of PVR. So if you have a large and posterior retinectomy, you stimulate, this is my impression, it is my impression, but not only impression, it has also a pathophysiologic rationale, it stimulates the PVR. So what you want to reach with a retinectomy is to reduce the traction. Quite often you cannot reattach the retina when there are traction left, but it is not, the aim is not to reduce the effort of a surgeon. So in my opinion, what you should do is to remove all the traction and only at the end do the retinectomy, not try to remove all the retina where there are traction. There are different kinds of traction. One of the trickiest is the anterior loop due to contraction of the vitreous base. I say it is tricky because you really need to depress the sclera to visualize this kind of traction. And this is why, in my opinion, especially in trauma cases, it is really very important to do an anterior vitrectomy remove, to clean the vitreous base to prevent this kind of traction. Because when you have this anterior loop, you have a shortening of the retina. And if you cut, like in this example, you want to cut out the star fold and the anterior traction, you run the risk to end up in a very posterior retinotomy. So it is very important to start removing this kind of traction. And then you can have a centripetal traction to the center and also the tangential traction. So any kind of traction should be addressed with a proper technique in order to remove all the traction before you go on and do a retinotomy. Or better, not really a retinotomy, but a retinectomy, because I think you need to remove the anterior flap, but it is not vascularized anymore. So you should make sure that there is no traction at the edge of the tear, of the retinotomy. But in my opinion, it's also very important to release the traction. I don't like, Julio knows this very well, I don't like to leave a C-shaped edge, because when you have a postoperative traction toward the vitreous base, then it can lift up the plane and detach the retina again. And so I like to open, as we see the red dots, to make a L shape or a U shape, not a C shape retinotomy, also all around the retinal tears. So the starting point is release all the possible traction, and you end up with the smallest and as anterior as possible retinotomy, but avoiding traction at the edge, as I just said, with an U or V shape and not a C shape retinotomy. Do you agree? Any comment on this topic?
Yes, I agree. I have seen it there in Italy, and here as well we perform it the same way.
But
Alberto,
I will stress absolutely relieve all traction. Usually when we see a failure of the retinotomy, it's probably well done, the retinotomy, but there is no in the retina. That's absolutely the main reason of failure in these cases. You show very clearly this nice picture. You have to take your time, release, work and work and work. Vitrectomy is not done in 15
Patient. Yeah.
Patient and patient. Okay.
Yeah.
That's the main point. And also, I absolutely agree with the technique of retinotomy. I agree with everything with you.
Thank you. Thank you very much.
Grazia, tell us, please, how do you perform the retinectomy in the periphery? Do you perform it with the vitrector or with the scissors?
It depends a little bit what you have. You should take into consideration that if you use the cutter, you remove more retina than if you use a scissor. So for example, when I do, for example, choroidal transplantation, and I like to remove as less retina as possible, I use the scissor. But in PVR cases, I usually use a cutter, but I stabilize the retina with PFO in order to make sure that I don't remove too much retina for the reason I mentioned. I don't want to end up with a posterior retinotomy.
Okay, thank you. And you showed us before that you remove the subretinal clot that sometimes appear in these trauma cases? And are there any time that in which you leave this clot, or you try to always remove it? We know that leaving this clot for some time will decrease the vision of the patient in the long term.
I answered this after a couple of slides, because I'm going to speak about vitreous hemorrhage, and then we can mention it, and I will answer this question. Okay?
Okay, please carry on.
Yeah. So we mentioned you have a good cornea because there is a posterior laceration, but in some cases you have a very bad cornea, like in this case. And then, in fact, you have to decide what you do. Of course, you cannot do a vitrectomy through this cornea, and you should take into consideration endoscopy, but I don't have access to this technique. And so the only solution for these cases is to proceed with a corneal transplantation, temporary keratoprothesis. You see the picture, and the quality of the image you get are very good after a temporary keratoprothesis, and then you end the operation with corneal transplantation. Indeed, Julio mentioned the vitreous hemorrhage and the toxicity of blood under the retina. And so I completely agree that it is important to proceed with a vitrectomy, let me say, within 10 days, usually, if it is possible. You see here the condition of the cornea after a fresh transplantation. But so I like to remove the subretinal blood whenever possible, within 1 week, 10 days, to prevent irreversible damage. In some cases, after a vitreous hemorrhage, you have this condition, an hematocornea. This is a terrible condition. Usually it is, you see also in this case, there is a hypotony, the eye is very soft. And when the eye is soft and there is a vitreous hemorrhage, or better, an anterior chamber hemorrhage, you can end up with a very bad cornea, hematocornea, within 1 week. And it is a terrible condition. What you can do is, if you have such a cornea, you can take into consideration to use the same cornea for retransplantation. So you remove it, you use a temporary keratoprothesis for the time of a vitrectomy, and then you reapply the hematocorneas, the bad cornea, because within a couple of weeks, not weeks, months to be honest, you end up with, it will become clear. So if there is no other reason to do a transplantation to prevent an autologous transplantation, you can use the same cornea, and it is particularly important to know. But even better than to do a transplantation with the same cornea, because the disadvantages, the advantages that the patient, there is no risk of corneal rejection, of this kind of problems. But of course, you need a couple of months before you can visualize the retina and the fundus. And so in these cases, it is very important to prevent the hematocorneas. You see here the condition immediately after the suture, so that the cornea is still bad and you cannot visualize the posterior, the fundus and the posterior pore, but after some time it will become clear again. But there is a way to prevent an hematocornea, and the point is you really need to know this and to prevent it. And you can do this avoiding that the blood comes in contact with the cornea. So what you should do is inject viscoelastic material in the anterior chamber and increase the intraocular pressure and prevents that the blood comes in contact with the endothelium. And you see here there are fresh stitches, so it is just suture. So it is tricky to go on and do a vitrectomy now, but if you inject enough viscoelastic material in the anterior chamber, then you can proceed with vitrectomy 7 or 10 days later and with a clear cornea. So if you see a trauma with blood in the anterior chamber, just inject under topical anesthesia some viscoelastic material to prevent this, this condition. It is, in my opinion, very, very useful. What to do if you have a massive hemorrhage? Let me say, you can prevent, you can keep the cornea transparent, but when you have a massive hemorrhage in the posterior part, and you cannot see where to go and where the retina is. The rule in general is go on very slowly, nasally, to prevent temporal retina, especially retina in the posterior pole. And so you go on in a vertical fashion. So you go deeper and deeper in a very limited area until you find the retina. The idea of going on nasally, as I said, to prevent damage of the posterior pole, and even if you unlikely cause a break in the retina, it is anyway in the periphery and in the nasal part. So you see, when you have the impression that you find something that can be retina, you try to enlarge it and define the plane, and then detach the retina, detach the vitreous all around this area. I think you can get, probably it is quite dark, but this is retina, this is detached vitreous, and so you proceed slowly until you can put some viscoelastic material in viscoelastic or PFO, and then you see, when you visualize the retina, then you can proceed rapidly, more rapidly, because it is safer, but it is important to find the right plane. Other questions about vitreous hemorrhage?
I agree, it's very important to approach a little sector of the vitreous so that we cannot enlarge a retinal hole if we accidentally approach the retina. Regarding the previous topic that you mentioned, the corneal transplant, do you have any changes in your behavior when you have a trauma case in a child?
Yeah, in a child, and it is not infrequent, you should evaluate there are many factors you need to take into consideration. First, can I operate and reattach the retina without corneal transplantation? In these cases, what I usually do, I do the operation, I try to spare the own cornea and see if it is worthwhile to do a corneal transplantation, because sometimes you do a vitrectomy and you see that the retina is badly damaged in the posterior pole, and your aim in this case is to save the globe and the cosmetic aspect and not really the function, because sometimes in small children you have the amblyopia problem and this kind of things. And if you had corneal transplantation in one eye, but has not potential for visual recovery, I don't think it is meaningful. So I usually try to avoid at the first operation, corneal transplantation whenever possible in children. Quite often when you have large corneal laceration, you have damage of the lens and the iris. And so I've got quite a number of cases where I did a lens implant and also an iris of a lens with a diaphragm, painted diaphragm of the nice iris transplantation in combination with a cornea transplantation. So I usually try to avoid during the first operation whenever possible.
Okay.
Do you agree?
Yes, sure. Do you have any questions, Tomás, Alberto, Gastón? Sí, adelante.
Hola. Hello, Grazia. I have a question. In this kind of cases, we are in the area of microincisions. What do you think about the caliber of the instruments? It is important in this type of surgeries, in this kind of patient, or really no?
Now, you know, I think the caliber of instruments is not the main problem, of course. I like to use valved transconjunctival approach instead of 20 gauge approach because you can keep the intraocular pressure due to the valve trocars. Because I think you can do everything even with a 23 gauge. I don't use 27 or 25 in these cases because it is not the problem of how large the instruments are and how large the sclerotomies are. It is not minimal surgery, minus invasive surgery. But I think that the trocars and the maintenance of intraocular pressure at all times and the possibility to increase the intraocular pressure if there is a bleeding, it is a plus value. It is important to have this possibility compared with 20G normal non-valve trocars surgery.
Perfect.
Okay, thank you.
Do you agree?
Yes.
I think
yes.
that, may I?
Sí, Alberto.
Sure. Go ahead.
I think that smaller diameters, they are not so good in trauma cases because we have to manage a lot of fluid movement. I mean, removing blood, clots, and so on. And the smaller one are not so good. So I would say that the smaller one I would use is 23. And, and why not 20? Because 23 has the capability of trocars and, as you said, I won't repeat it. But smaller one, they are more difficult and there are not any advantage in these trauma cases and in many other cases also.
Yeah, I think indeed, yeah. To be honest, at present, the trocars and the cutters are quite efficient, even in 25 gauge. But I think it is really not the problem in these cases, and 23 is fine. It is fast enough. Otherwise, you have a long time for vitrectomy, clot removals, and the disadvantages are really more than the advantages of using a small gauge trocars. I completely agree with you. Now, the principal problems, the challenges of this kind of surgery, you shouldn't try to use minimal surgery. It is a big problem, not minimally invasive surgery. I completely agree.
Okay.
Okay, please carry on, doctor.
Yeah. Now, let's move on. We've spoken about scleral laceration and open globe traumas, but in some cases, another large part is concerned with intraocular foreign body. In my opinion, there are very few exceptions, and intraocular foreign body should be removed. But sometimes it's not easy to remove them and to find them. And we see here one tricky case, and you see how embedded this, not this large, not small, piece of iron was behind the iris. In this blood clot, you see it is covered by blood, and it was really very, very hard to find it. So the philosophy, so to speak, of the technique of foreign body removal, in my opinion, is very similar of what you should think about the capture of the killer. If you think of video clip about the capture of a killer, the key steps might be: first, evaluate the scene of the crime, what happened, then choose the right instrument to approach the killer, prepare a safe way out after the capture, and then make sure that the killer cannot escape after the capture. And don't damage the surrounding during the action. This is what you can imagine for the capture of a killer. And in fact, for the eye, intraocular foreign body is a kind of killer. And so we should apply the same idea, so to speak. Now, first of all, evaluate the scene of the crime, we said. So evaluate the condition of the globe. Where is the entrance? We should ask ourselves, where is the entrance wound? Sometimes it's clear, sometimes it is not clear. So if we see, like in this case, a small hemorrhage, we really should go on and look, is a perforating wound or not? The other question is the wound leaking? It is important to decide the timing of the Sturber's surgery. And is there a prolapse of intraocular contents? And it is not only iris, but it can be choroid, it can be things that can condition, for example, a sympathetic ophthalmia. So really take care what happened, what I'm facing, what should I do? So you see here an incarcerated iris. Then it is important to know if there is an intraocular foreign body, how large it is, and where it is. You see here the picture of a large foreign body. It is not a small one, it is a 7mm foreign body. Nevertheless, it was quite difficult to find it. The surgeon who did the first operation was not able to find it because as you see here, there is in the anterior part, there is all the fibrotic tissue, some blood left, and a contraction of the vitreous base, an anterior loop. And in fact, you cannot find at the beginning, and I couldn't see at the beginning, the foreign body. And so trying to remove, you see how hard this fibrotic tissue is and how difficult it is to remove and detach it from the retina and to remove the anterior loop in this area. And you see the technique is a bimanual technique. You can depress the sclera with one hand. This is a vertical scissor. You see here the infusion line was captured in this fibrotic vitreous or whatever you can call it tissue. And so now it is finally free. And this is even a depression bimanual surgery with independent chandelier, but the depression of the sclera from an assistant to be able to detach. So you see here I'm removing the fibrotic tissue, seeing the retina behind, with the idea of removing as less retina as possible. And you see here this clot, it is fixed to the iris. You see the depression here of the iris. And the foreign body turned out to be in this, behind the iris, embedded in the blood clot. And you see how hard it is to make it free from this fibrotic tissue. Although we had seen that it was quite large. Then an important thing is protect the corneal endothelium before removing of the foreign body. So you inject it and make sure you have the right instrument and the incision is large enough. And you see in this case how large the foreign body is. And then, of course, you can proceed with the cleaning of this tissue and the vitrectomy later on. But you see in 1 month how sticky and fibrotic the tissue was become. So it is very important to remove the foreign body timely and to remove also the cortical vitreous to prevent postoperative traction in these cases. And then, of course, you, after a careful removal of this cortical vitreous, you see how important bimanual surgery is. And you proceed. And this is, again, still there, a part of the fibrotic tissue. Then some laser, the retina here is already reattached with PFO, and you do some laser and silicone oil to remove it. This was the condition at the time of silicone oil removal. So remove the silicone oil, but in the area where the foreign body remained, there was a scarring tissue that pulled the iris in this direction. So after removal of the silicone oil, you see the bubble, you see the scarring tissue at the time, at the area of the impact. And then the iris was, there was a scarring tissue in this area, but it was possible to remove it. And so you see the iris is back and you have again a round, nice pupil, and you can fix an iris fixed IOL and then an pupilloplasty to keep it round. And so finally we ended up with a nice round pupil and a fixated IOL. And it was a very lucky case at the end because this kit, 9.
Now, you extracted this foreign body with a special forceps, which is from the otorino laringología.
Yeah, correct. Okay. It is indeed, I'm going to discuss it because it is important to use the right instruments, because when you have such large foreign body, it is very important to choose the right instruments, because you cannot approach it with a normal scissor, a normal forceps. You see here, for example, we have this large, you see on the right part of the screen, forceps from the, let's see if I can get the pointer back. No, too many technical problems. But now you see on the right of the screen.
Yes.
And
yes,
it is the typical forceps from the nose, ear, and throat doctors with bented. It's not easy for us to use them, but you see how large it can be, and it can have a good grip on the foreign body, as you notice, Julio. On your left, you see a basket-like forceps. It's not too large. It permits to remove a foreign body of 0.2 millimeter, no larger than that. But we will see another example where we borrow sometimes instruments for other specialties. We said, foreign body, you grasp it, you get it. Be careful not to tear the vitreous. You see here a picture, you have a foreign body here. You really need to remove the vitreous before you try to remove a foreign body, because when you pull the foreign body through this pocket of vitreous, you run the risk to create traction on the retina, lacerate the retina. So very important, do a careful vitrectomy before you start removing the foreign body. Then we said, make sure that you grasp it carefully, not leave it fall down. At least try it. Not what I did in this case. You see a tiny grasp, and then I tried to grasp it with a second forceps and it fell down. So it should be important to, in this case, it was a small foreign body, but if you have large foreign body like this one that falls back to maybe to the posterior pole, you can have serious problems. Then you should evaluate how large the foreign body is and prepare an exit line large enough. Sometimes it can be useful to enlarge a sclerotomy, but sometimes if the capsule, there is no lens, no IOL, you can make a posterior capsulotomy and remove it from the anterior segment, protecting the endothelium from the contact. And in this way, you can remove quite large foreign body without major problems. But make sure that the incision is large enough, even for the cornea, because if it is not large enough, you tear the endothelium, you damage the cornea, and it's much less stress for the cornea if the incision is large enough than if it is small. You see here, make sure grasp it carefully, and then you should try to remove it without stressing the cornea. This is a case, my final case. It was referred to me, and this is the condition of the retina. Format holes and breaks, because what happened was that the previous surgeon tried to remove this very large piece of glass, without succeeding, and this piece fell down on the retina a number of times, causing large breaks, as you have seen. So we decided that foreign body was too large to be removed in the conventional way. So we borrowed this basket from the urologist. They use it to remove kidney stones. And it is about a little bit more than 1 millimeter, 1.1. They have different sizes, of course. And you can push out the basket that becomes large enough, as you see. And so we are using a bimanual technique. One hand is used to push the piece of glass inside the basket. You see now the piece of glass is firmly grasped and blocked inside this basket. And in this way, you can pull it to the anterior segment. You see, it is quite easy to imagine that this piece, if you try to remove the conventional forceps, it falls back to the retina. And it was necessary really to enlarge a lot. And you see in this way, with one hand, you prepare the corneal side, and only when this is firmly grasped with the first hand, you can leave the basket and remove this very large piece of glass. And then, of course, you need to take care of this bad condition of the retina with large breaks. So it is extremely important to avoid that this foreign body falls back to the retina. So I will stop a moment. And I will show you my final video. And it is a video where a pole-to-pole surgery is necessary. And then we can comment on it.
Irrigation down 25.
Man with a 45 meets a man with a rifle. You said the man with the pistol is a dead man. Let's see if that's true.
Ooh, terrible stitches. Shouldn't be too comfortable. Left eye's gone. Bad cornea here too. Can't see enough. Extreme solutions to extreme situations.
What are you doing?
Trying to open the pupil.
What's this?
I don't know.
Where's the lens?
No idea. Let's check the infusion line. Time for the keratoprosthesis. Ah, the retina.
Looks like a lunar landscape.
Pay attention instead. To delaminate, you can use closed vertical scissors. Or a blunt pick. And the curved scissors can be handy too.
Looks like flowers on the macula's grave.
Don't bring bad luck. Finally, we got him.
What aid?
Let's get rid of the subretinal strings. Some laser. Silicone oil.
So you see how even in this very bad condition, it is possible to get some ambulatory vision back. And so I thank you very much for your attention, and I'm here for discussion if you have any question.
Yes, thank you very much, Doctor. These cases were very impressive. The last one won a prize, right? If I...
yeah, indeed. It was presented at the American Academy some time ago.
Yes,
indeed.
yes. It's a famous video, actually. Okay,
probably you refer to the one with the pink panther. This is not this one.
Ah, okay. I think I've seen this one.
We can speak about choroidal transplantation, and then I will show you the video of the pink panther. This is probably the famous one.
Let me ask you a question. You told us that we don't have to give up in any of these eyes. I completely agree. And do you agree these eyes with no light perception are still, do they still have a chance for you?
Yeah, I think so. There are eyes with no light perception when there is a vitreous hemorrhage, a dense vitreous hemorrhage, where it is worthwhile to try to operate. This is the only case, in my opinion, where you can have a chance to re-establish vision in an eye with no light perception, only after a trauma. In diabetic cases, in other cases, if you have no light perception, there is usually no chance to recover some vision, while in trauma cases, it's worth to try.
Okay, thank you. Let me say something in Spanish, doctor. Perdón, 12:30 se desconecta de Faco Extrema. Los que quieran seguir conectados para las preguntas de la doctora pueden conectarse a través de la plataforma de Facebook de Capacitación Fundación Zambrano o a través del link que hay en Zoom para conectarse también. ¿Sí? Pero 12:30 nos avisan que de Faco Extrema se va a estar desconectando de esta charla. Thank you. It's something about the connection platform. Do you have any questions, Alberto, Tomás, o Gastón?
More than question, I have una riflessione, direi.
Bene.
I should say, the main object of our surgery is not the foreign body, but it's the eye. And you showed a couple of cases. I always say that in my classes. Let's think about the eye. And second, as I said before, when you were trying to connect, I'm not doing primary surgery in trauma anymore. I just do, because you can see my hair. And anyway, do you still use this pickering, these magnetic pickerings inside the eye? There are, instead of,
no, I use this
20 gauge. I don't know if they still make these pickerings. Magnets.
Yeah, we do have magnets in our OR. I think I used the last time this 10 years ago. and it was for a small foreign body with an intact lens of a young boy. And I used to pull the foreign body to the center of the vitreous cavity to prevent to touch the lens. But I think it's very rare to need it because nowadays we have less invasive and safer techniques to remove foreign body than to put the magnet inside the eye and try to attract the foreign body.
It's not exactly what I meant. I think it's using as a forceps. I mean, as a pickering.
As a
foreign body. Some of these small foreign bodies are so flattened to the retina that it's very difficult, or could be difficult to grasp with the forceps. You can touch the retina, and with this small, it's not an intraocular magnet; it's a pickering magnet. That means you touch the foreign body and put and then you do the usual maneuver of
yeah. You are absolutely right. This is a tricky point, the removal of this foreign body. I don't have a magnetic pick, but I use normal pick. And I completely agree with you. It is necessary to use bimanual surgery. And what I do is I go inside with a pick, lift up a part of the foreign body, and then grasp it. Just to prevent trying to grasp it, you push it against the retina. Correct. Absolutely agree.
Okay.
Yeah.
Okay, doctor, regarding the open globes in general, do you usually close it and then wait a couple of days and then do the secondary procedure, or do you try to do it all at the same time?
Yeah, it depends on how large the lesion is, the laceration is. If it is small one, you can proceed it. You close it and you can proceed with a vitrectomy if there is a vitreous hemorrhage or a foreign body. When there is a large one, I usually postpone it, the surgery, the major surgery, because when you have a large laceration, the risk of intraocular bleeding and intraoperative bleeding is higher, and I prefer, and also of leaking of the wound and so on, so I prefer to postpone about 1 week. When there is a foreign body, I usually try to remove a foreign body at the same time.
Okay. Okay, thank you. And you showed us the basket. Excuse me. You showed us the urology basket that you used to take out this large foreign body. Do you have experience with the other basket, which I think it's smaller?
We do have the other one, what I showed on the left of the slide.
Yeah.
It is a Morse basket, 20G, an ophthalmology instrument. But as I said, you can grasp a foreign body of maximum 0. It depends on the shape, of course, but maximum 0.2 millimeter. So you can grasp very large foreign body because it opens, but not so much. So I think it is useful if you have a small foreign body.
Okay, and you need an assistant to...
No, for the one in use for ophthalmologists, not, because
no, the other one.
Normal instruments, and then you press the instrument and you put out this basket and then you retract it so you can use without an assistant. For the one of the urologists, you need an assistant.
Okay.
Yeah, okay. Because you should ask to retract the basket, and you control only the end, but you cannot control the movement of the basket. But the instruments for ophthalmologists, you can control it by yourself. In fact, depending on the companies, there are different shapes and different functioning, but in general, you can control it by yourself, but not the one of the urologist for kidney stones. You need an assistant.
I think, Alberto, you have a comment?
But this is not my class. It's Grazia class. But I was delighted. I was delighted to see your first case of intraocular foreign body, because when you remove the foreign body, you went on and on and on and on. As I always said, the surgery on intraocular foreign body does not finish with the removal of the foreign body. You have to clean the vitreous base, you have to clean the vitreous, you have to control bleeding, you have to go on and go on and go on. And it was very frequent that you see a patient that had this foreign body removed and came with a secondary complication, or with a secondary, it's not a complication, it's a development of the PVR that was not avoided in the surgery. You were interrupted at that moment. Perhaps I'd like to stress the thing you did. You went on, insist and insist and insist. I think that's the secret of vitreoretinal surgery.
Absolutely. Okay? Especially in trauma cases, it is in details. It is so important to see the details and to clean the vitreous base and to prevent anterior loop and to prevent traction, to prevent retinal incarceration in the laceration. I completely agree with you.
If you allow me, once I presented in the Spanish Retina Society with some of friends you really know. I presented a case, and then the second surgery and third surgery, and finally got and cured the patient. And as one of the chairman, I will tell you who, said, Alberto is not curing people because he's good. He's curing people because he's persistent.
Yeah. Yeah.
And I think that's the secret of
vitreoretinal surgery is about patience and persistence. I completely agree with you.
Okay, thank you.
You are right. You are right. Thank
Doctor,
you for your comment.
Regarding those cases which large vitreous hemorrhages, you showed us to approach it from the nasal side, just a little sector, and then enlarge it when we see the retina. Which parameters do you use with the vitrector when you're at that point? And do you have a machine preference? I know you use the Constellation and the EVA.
Yeah. If I can use the flow control vitrectomy, I prefer it. So with the EVA, you have a choice between the two pumps, flow control and vacuum control. And in this case, is as you want to remove a little bit of vitreous at one time and not too much, and not to have too much aspiration, the flow control, in my opinion, it's better. And otherwise, if you have a machine like the Constellation, a vacuum control machine, you just put the aspiration very low, because with a detached retina, if you use high aspiration, before you notice it, you can have a big hole in the retina. And so if your aim is to remove the vitreous to reach the retina and to detect where the retina plane is, then you should use a low aspiration or low flow, depending on the pump you're using.
Okay. Tommy, do you have any question?
Yes, Dr. Esa, thank you very much for the presentation. I like it very much. When you use the temporal...
Tommy, no se te escucha. Se te corta.
This time we missed him.
Yes. We missed him.
Sorry.
Maybe
now,
he can.
now I'm having problems with internet. Now you listen. Now
Ahora
you
sí, ahora sí,
No.
ahora sí.
Yeah.
Ahora no.
Change the parameters of the machine. No.
Yeah.
Ahora sí, ahora sí. Decime.
Ah, okay. Sorry.
Sí, está inestable.
You change the.
No.
Se corta. Tommy, mándame la pregunta por WhatsApp y yo se la hago. He will send me the question and I will make it to you.
Yeah,
Okay.
the connection is.
In the meantime, in these cases, in these trauma cases, when you have a retinal tear that has to do with a foreign body, or just a regular one for a regular trauma, do you always leave the patients with silicone oil, or sometimes you leave them with gas or air?
No, I leave them, it depends on how bad the trauma is. If there is no choroidal involvement, then I tend to leave it with gas or air. When the choroid is involved and there is a choroidal scleral laceration, then I have impression that the risk of PVR is much higher, unless it's really a point shape. But if it is a bit large, let me say, large, it means more than 0.5 millimeter, 1 millimeter in size. If there is a sclerochoroidal laceration, then I tend to leave it with oil, because in my opinion, the risk of PVR is quite high. Then I want to do a choroidectomy, and then you enlarge the retinotomy, the area of without retina, and then I think it is better to get it to put oil inside.
Okay, I'll ask you the question Thomas was trying.
Yeah.
If you change the parameters of the vitrectomy when you used the temporary keratoprosthesis?
Yeah. No, in fact not. You can put even a high intraocular pressure, no problem. You can keep it. You need, of course, to suture the keratoprosthesis in advance, but you can maintain quite high intraocular pressures, no problems.
You usually leave it up to approximately.
No, I usually do a vitrectomy with 20-25 millimeter of mercury, but
Okay.
let me say you have an hemorrhage and you want to put it at 60, you can do it.
Okay.
Yeah, there is no problem of leakage in general, if this is the question.
And you use regularly the Eckhart prosthesis?
Yeah, in fact, I have the Eckhart and the Landers prosthesis, and I prefer the Landers. The Eckhart is the silicone one, and you have to suture it, and you can put 3 sutures, while the Landers is an PMA prosthesis, and it has preformed holes where you have to suture. And in fact, usually I prefer the PMA prosthesis. I think it's more transparent. I prefer it.
Okay. Okay. Is there any more questions? Tomás, Alberto, Gaston?
Yes, doctor. And you show us, you put the artisan lens behind the iris.
Yeah.
You do that always in trauma, or always in any aphakia case?
No, it depends a little bit. It has advantages and disadvantages. When you put it behind, you prevent corneal contact. So I usually use it if I do a cornea transplantation with a weak cornea, a bad cornea. It has the disadvantages, especially in children, but if you put it behind and then during his life or her lifetime, it loses the grip, when it is more difficult to put it again in size and even to notice this point. So it depends a little bit on some colleagues of mine prefer to put it behind all the time because you cannot see it from a cosmetic point of view. But in fact, in children, especially in children, I prefer to put it be in front, in the anterior chamber, let me say, in front of the iris.
Okay, thank you.
Thank you.
Nice.
Are there any other question? Alberto, Gastón? Del público no tenemos ninguna.
No, de mi parte tampoco.
Okay, so I think there's no more questions. Doctor, thank you very much for your tremendous presentation. I think we all have been delighted with it and with your presence as well. In spite of the connection problems, but I think it was worthy to wait, and I hope that we can organize some other thing in the future.
For sure, for sure.
Okay.
Thank you very much for having me. All the best.